Thank you, Candace. So we have had the current social care system for, as Candace said, 70 years. But it's 20 years since the Royal Commission published, almost exactly actually, 20 years since the Royal Commission published this report calling for a wholesale change to the social care system of delivery and funding. Now, whilst that triggered some change in Scotland with the introduction of free personal care, unfortunately in England, it gained little traction. And so what we've seen over the last 2 decades is a succession of reports and reviews, inquiries, even some legislation. This is just a sample, but no actual real proper reform. And now here we are in 2019, awaiting a green paper, promised nearly 2 years ago, but I'm told it's soon. So while we've been waiting for that green paper, on which now a lot of hopes are pinned, we've been looking to other countries to see what they've been doing in this area. And as Sir Andrew very eloquently put this morning, we're not alone in facing the challenges that we do around our ageing population. At the moment, about 5% of our population is over 80. That's going to increase to 8% by 2040. But when you look at Japan, they're already there. They're 20 years ahead of us in terms of the demographics, and Germany is hot on their heels. So by looking abroad, we can almost look into our future to see how these countries are dealing with their future, their care needs. And of course, it's not about just the older population. Adult social care is just as important, but I think the demographics and the change in our population help to set this in the context and give us a sense of the scale and the urgency of the challenge. And of course, our demographics don't just dictate and determine the level of need that we have, but they also have implications for how we fund that care. And this diagram just shows the old age dependency ratio. So at the moment in the UK, for every 10 working age adults, there are around 3 people over 65. That's going to increase to around 5. So for every 2 people in work, there'll be 1 person over 65. Japan, again, is already there. By 2050, for every 10 people in their working age, there'll be nearly 8 people over 65. So these are really quite stark demographics and challenges that we face. So while we're not alone in the challenges that we face, we are in a small minority of developed nations that hasn't properly grappled with the issue of social care and reformed our social care system. So we've been looking at 2 that have managed to do this. And Germany and Japan present quite interesting examples, not just because of their demographics, because of the way that they have approached reform. So over the next 15 minutes or so, I'm going to present 5 main lessons I think we can learn from these 2 systems. And it's important, obviously, to acknowledge there are contextual differences, and I don't want to present these as perfect systems, but I think that we can learn from their imperfections as well as their successes. So I have about 15 minutes to set out 2 incredibly complex systems, so apologies to the nations of Germany and Japan for reducing huge nuance and detail into a set of slides. So as we've talked about already this morning, in this country, we find it very difficult to gain political and public support for radical reform, as evidenced by this succession of different papers. And what we've seen over the last 2 decades is that social care proposals for reform have been set out largely at election time, when there's very little incentive for politicians to collaborate and work across party. And it's quickly turned into a very politically divisive conversation. And that's not helped by low public awareness of how the system works. I think the LGA's survey last autumn indicated that around 40 or 50% of people still think that social care is funded by the NHS, it's part of the NHS. So it comes as a big surprise to people that it's not. So it's very difficult, I think, to have that debate with the public with that low level of understanding. But Germany and Japan started from a similar point. It's not a dissimilar story, actually. And one of the surprising things from our trips abroad is that their discussions took a long time as well. So Germany started talking about reform to their care system in 1975. And the 1980s saw the publication of a succession of reports and inquiries and reviews. Sounds familiar. It wasn't until 1995 that they managed to enact reform. Similarly, in Japan, pressure from the ageing population grew over the 1980s and put pressure on the health service. But reform there didn't happen until 2000. So maybe that gives us hope, I'm not sure. But I think a difference between where Germany and Japan were when they enacted reform and where we are is that there was widespread public pressure for change. So there was a good understanding of the problems in the system. There was widespread discontent at the lack of care and the high costs, and that is what helped drive reform. And then once those discussions reached the political sphere, the discussions sought to directly address the issues of concern to the public, went with the grain of social change and social trends, and tried to create a system that supported and enabled social change. And I think it's interesting to note that in both countries, the window of opportunity came as a result of economic and political upheaval. So in Germany, it came in the form of reunification. And whilst that delivered some economic challenges, it opened up a different political discourse and forced to the fore some of these issues that have been kicked into the long grass. Similarly, in Japan, the economic crash of the 1990s created some political upheavals, and therein lay the window of opportunity. Now, I don't know if Brexit is our opportunity. It doesn't feel like it right now, but you never know. So by the point in time that real reform was on the table, people were convinced that change needed to happen. And the discussion was how to solve it, not if to solve it. And I don't think we're quite there yet. Now, I don't need to tell anybody in this room about the challenges of social care funding, so I won't. But I pulled out this quote from one of our interviews in Germany, and the interviewee was saying, well, why have you come to Germany to learn? What can you learn from us? You have the NHS. So we explained our social care system, and this is her response of total surprise. I think it echoes some of the things that Sir Andrew was saying. I always thought that Britain was not that poor, but you're telling me there's no way of taking care of something which is not an exception but the average. Either you've got money or bad luck. And I think that quite clearly sums up the situation. So what have Germany and Japan done in this area? Well, they've got slightly different systems, but they both have similar principles. So they're both about collective funding. Everybody pays in to a central national fund. In Japan, it's from the age of 40. In Germany, it's once you start employment after the age of 23. Now, they're both based on social insurance systems. So Germany has a pure social insurance system, by which I mean those contributions are paid into a specific fund, which is administered by an arm's length but publicly owned body. And the government has very, very few powers over that pot of money. They can't put money in, they can't top it up, they can't divert funds. So there's a transparency there. It does make it quite inflexible, though. So Japan, when they were designing their system, wanted a bit more flexibility. So they chose to fund it partly by social insurance for that transparency that it gives the public, but also half from taxation, so they have a bit more flexibility. There's also a clarity in these funding models. So contributions are a fixed percentage of income, and people pay in every month. It comes off your pay slip, and that burden is shared with your employer 50-50. And the contribution rates are around 2.5% to 3%. And retired people continue to pay in. So with that recognition that the wealth actually in the older population is increasing, they pay in the full percentage out of their pension. So that's an attempt to address that intergenerational fairness. Now, one of the other issues I think we have in the English social care system is a deep sense of unfairness in that eligibility and access to services and funding varies quite widely depending on where you live. And the prices that you can pay as a self-funder also vary quite widely. And I think that gives a sense that the systems, well, it's very confusing for people trying to navigate it, but it's also quite deeply unfair. So both Germany and Japan have taken the same approach to this. They've created a national framework for eligibility and benefits. So it doesn't matter where you live. You can live in Berlin or Dusseldorf. You go through the same process of eligibility. And through that process, you're assigned a care level. In Germany, it's 1 to 5. In Japan, it's 1 to 7. And that consistency gives a nice clarity to the system. Now, that care level that you are assigned when you need care is associated with a fixed monthly budget for care. So it doesn't matter where in the country you live. In both countries, you get the same monthly sum that you can spend on your care. So there's a nice clarity there. And just for clarity, that monthly budget is for care needs only. So if you're in a residential or nursing home, there is an extra fee, hotel costs, which is for board and food, which I think is similar to the Scottish system. But the two systems diverge slightly here, and I think it's interesting to just reflect on some of the detail here for our own thinking. So in Japan, benefits are given in kind only. There is no cash in the Japanese system, and that was a very deliberate decision by the government because they wanted to shift the care burden from families onto wider society. And there was already trends with the breakdown of the traditional family, but because of its stark demographics, they also needed to release more women into the workforce. So there was a very deliberate decision there to keep it in kind. I'll come back to the challenges that poses. In Germany, it's slightly different. You can choose to take your benefits in cash or in kind or as a mix. Now, care is not free at the point of use in Japan. When you access care, you pay between 10 to 30% of the care costs, and that's means tested. But importantly, that monthly fee that you pay is capped at a certain level. So even if you're at the highest care level and in a very intensive care setting, even if you're paying 10% of those care costs, that will be capped at a certain monthly level. So you're not penalised for having higher care needs. And importantly, that system is consistent with the health system. So in Japan, people are used to accessing healthcare and paying a co-payment of around 10 to 20% for healthcare. Now, they're slightly different in Germany. So the system was set up to cover basic costs, so to ensure that everybody had access to basic care. But it was intended to cover around half of care costs, so people were expected to top up the other half. Now, there's no cap on that. So whilst the costs of care have risen over the last 25 years, the benefits have not increased in line. So people are now facing quite high costs, which is leading to some discontent. And it almost feels like they've come full circle to a point where people are facing unacceptably high costs. The other point about the German system that I think is important for us to note is that it's not consistent with its health service. So whilst the German health system is free at the point of use, its care system is not, and that comes as a surprise to people. And one piece of advice that policymakers that we spoke to and politicians said, if they could give us one piece of advice, it would be to make it consistent with your health service so that people understand that and it helps to gain that public buy-in. One of the other key problems in the English care market at the moment is instability, with care providers handing back contracts and going out of business because of the downward pressure on fees. And obviously that has a huge impact on care users. And so Germany and Japan have faced this issue and created a national fee schedule in order to create a stable and competitive market. So it's a bit like the tariff in the NHS. So if you're a provider, you know in Japan it's rigidly set every 3 years. Every 3 years you know how much you're going to be paid per individual at care level 1, 2, 3, 4, 5, 6, 7. So there's a certainty there, you can do planning. And it's adjusted slightly for staffing levels as well. But it gives providers a certainty, and it has created a very stable and competitive market in both countries. It also allows the government to incentivise certain types of care that it might want to encourage. So Japan basically had no care market before 2000, and it really wanted to encourage entrance into the home and community care market. So it has increased the fees for those types of care and decreased residential care fees. And so there's an inbuilt mechanism there at the centre to control costs. Now, the fifth and final lesson is the most difficult one, which is why I left it for last. We're going to be hearing later from Candace about workforce challenges, so I won't go into too much detail here, and everyone in the room will be familiar with the challenges that we face with high numbers of vacancies and high turnover, and in the care market, low pay and status. So Germany and Japan face the same issues. This is the number one problem that they face. It by far eclipses any concern they have about financial sustainability of their systems. Every single person we spoke to said it's about the workforce. So we're not alone in this. But unfortunately, they don't have the answer either. But they did have some advice for us. The main bit of advice was to make workforce an integral part of funding and service delivery reform from the outset. And I think sometimes we have a tendency to focus just on the funding model without thinking about actually how are we going to deliver the system, who do we need to deliver it, and what are the implications of that for funding. And it's not just about pay, it's about conditions and status too. Now, both Germany and Japan are looking to recruit from abroad. That is a central strand of their strategy for trying to fill some of the workforce challenges. So we need to be mindful that we will be competing for the same staff. And whilst those countries are making their immigration systems more flexible and welcoming, we seem to be going in the opposite direction. And I noticed that a news story today of a German hospital has placed an advert in Guardian Society for nurses, Polish nurses specifically, inviting them to come back to live in a European country. So we need to be mindful that we are going to be competing in the same pool of people. And then lastly on this, I just want to sound a note of caution about technology and being realistic. And we've heard this morning about the potential of technology, but also that we need to be realistic. It has its place in delivering a more efficient system, but I think we need to be cautious that caring is a people-intensive business, and there's no two ways about that. And I'm often asked, when I said I've been to Japan to visit nursing homes, they said, well, everyone is looked after by robots, right? I didn't see one robot, and when we asked about robots, we got blank looks, and then we Googled a picture of a robot, and we got a blank look, and the answer was, we don't want to be looked after by robots. All of our policies are about reducing isolation. This is not part of our strategy. I just want to bust that myth. But I think a common theme in both countries is an acceptance that the reality is that we don't have enough professionals. We're not going to have enough professionals to meet care needs, so we need to think creatively about how we sustain the care system. And the two countries are taking slightly different approaches to this. So Japan is focused on harnessing the power of communities and really investing in volunteering. And they have a vision to create communities where people are able to live independently, so even people with dementia. And I think that reflects some of the comments this morning about dementia-friendly communities that we were hearing about. And there's a huge focus on prevention and keeping people well and independent and reducing isolation. So whenever we asked about the sustainability of the system, the answer was always, it's about prevention. That's the central strand of the policy. In Germany, it's slightly different. So there is a clarity of expectation that the family will play a big role in delivering care. That's well understood, it's well accepted. It's a very well-ingrained German value about the centrality of the family. And the system was set up in order to facilitate that. So the decision to include cash in the system was deliberately to help people look after their relatives. So at the moment in Germany, about 70% of people receiving benefits choose to take cash. So that goes into informal care. And we were told by policymakers that a main policy in Germany at the moment is to keep that level at 70%, because if it drops below 70%, the system gets into difficulty quite quickly. So there's a big focus on caring for the carers, making care easier to do by joining up policy across employment and families and communities. And they're trialling a number of policies around flexible working, unpaid leave, and interest-free loans to help people do that. So I'm often asked, would the German or Japanese system work here? And the answer is maybe, probably not. I think we need to be cautious about dragging and dropping a system from a different context into our own, because I think care, possibly more than anything, needs to be embedded in the culture and the social values and the trends that we have. But I think some of the principles from other countries could work. So I think fairness has to be at the heart of the system. By that I mean an ability to spread the risk of catastrophic costs across society so that they don't just fall on individuals. And I think there's a transparency in the German and Japanese system which has helped to build support and understanding of how it works. And that sense of consistency with national eligibility and benefits has really helped to gain and maintain that public understanding and support. I think there's an urgent need for stability in the provider market here, and I'd be interested to hear about reflections on whether some sort of national fee schedule might work in our context. But lastly, we need to think long term. We need to, if we have this opportunity for reform, which hopefully we have now or will have, we need to think about a system that will work now and inject money into the system now, but also work in 2040, 2050, when those population demographic pressures really bite. And we need to think holistically. So it's not just about the money, it's not just about the funding model, it's about the whole delivery of the system and the workforce and how we're going to deliver services to meet needs. But I think the first challenge we need to overcome is building a political consensus and public awareness and public support for change so that we can have a real debate about what system we really want and need, what we're willing to pay for it, and how we make that happen. And hopefully, the Green Paper will provide a starting point for that debate. Thank you.
So, the most immediate pressure on social care and the most immediate context for social care reform, I think, is money. Austerity's bitten social care particularly hard, and we have a manifestly unfair system of paying for it. But I'm not going to be talking about the money particularly today, because the gap between the lives that people want to live in later life or at times in our lives when we have long-term support needs and the lives that we're offering people through social care has been widening for decades, for much longer than we've had austerity. And some of those pressures on social care and on good lives are not actually about services, they are societal. So we've been talking already about loneliness. We have 3 million older people in this country who say the TV is their main or only source of company. We've never had and will never have a pill or a service for loneliness. The only cure for loneliness is love. And that's always proved fairly hard to commission for. So we have an immediate crisis, but then actually underlying that, we have a much broader set of challenges, a difference between what people are looking for and what we're offering. And despite the pressure, we can see fantastic social care happening. We tend to see it in small-scale initiatives and community initiatives. We often see it in examples of frontline workers who are acting with compassion and creativity, often despite the system that they're working within, which doesn't always reward or even facilitate that. And so we have what I think of as a bit of a paradox around scale. We have an intuitive sense that if social care does what it says on the tin, if it's social as well as caring, it's likely to be feeling small-scale, human-shaped, personal. We've had a whole personalisation set of reforms in social care for a number of years now, which the NHS is now developing as well. So the good stuff tends to feel small and personal, but the challenges feel huge, and the people in charge of addressing the challenges have to think big. They have to think about big populations, big workforces, big amounts of money, and we get a bit stuck. We point to examples of things which look as if they're the right thing, and we wish there was more of them, and then we go back to a service configuration or trying to shave another % off the care home budget. And I'm interested in what we do about that. How do we bridge that gap? And that gap between the people who have the power and are making decisions about what social care should look like and the people who are using it and this sense of what we think it should be offering goes back, I think, right to the origins of our public services. So if you look back to the Poor Laws and the origins of our public services, we built asylums and workhouses and orphanages, and we physically separated out those people who had long-term support needs from people we regarded as citizens. And we've demolished most of those institutions or turned them into luxury flats. But those ideas of institutionalization and that separation between people we regard as citizens and people we regard in some way as patients or as wards of the state is still embedded so deeply, I think, into our public service system that we can't escape from it. That's why I call my book Escaping the Invisible Asylum. We are constructing our own asylums that we're all, in many ways, crushed by within this system. And that happens as soon as people and families have any contact with our support system. We may have fewer gates, but we've got plenty of gatekeepers. We've got thresholds. We've got eligibility criteria. We've got ways of keeping people out of services, and also ways which become ways of keeping people in services often as well when they're trying to get out. And so we create these two separate worlds. A world in community, which is about capacity and potential and relationships, and then a world which can often feel dominated by need and risk and cost. And we've made various attempts to tear down those gates and to bridge the gap between those worlds, personalization being one of them. But we struggle to do that. So Meg is somebody who has been on both sides of that divide. She told us when we had a parliamentary event last year that she'd lived most of her adolescence and early adult life within mental health hospitals with significant mental ill health. And she got the medical care that she needed after a number of years to become well enough to return to the community. But community, of course, isn't a place, it's a set of relationships, and she didn't have those relationships. And she was stuck, and the system was stuck about where she could go. So Meg found out about a model called Shared Lives, which I'm going to talk a little bit about, and she was matched with one of the UK's 10,000 shared life carers called Hayley. So Hayley is somebody who's been through a 3 to 6 month approval process and has been trained and inducted to become a shared life carer, and then matched with an adult, in this case Meg, who needs support. Both parties decide to make that match and to share their lives. And somebody either visits their shared life carer regularly instead of, say, visiting a day centre, or they move in with their shared life carer, which is what Meg did. She lived as part of Hayley's household to get a whole range of support, some of which would come under the care agreement and what Hayley was being effectively paid for, and a lot of which actually was just what people do for each other when they feel like they're part of the same family. And when I meet shared life carers, particularly if they've lived together for years or even sometimes decades, they tend to say he or she is just part of the family and we love them. So what Meg talked about in the medical system was that she had a very fat file of risks and incidents and all of the things that she was most embarrassed by that followed her throughout that system, to the extent that she felt like she was regarded mainly as a risk. And now she started to feel like she's somebody with a future, like she's fully human again. And that was why she wanted to talk about the difference that that model had made. There's a slight slide transfer issue at the bottom there. So she runs a self-harm support group in her town. So Shared Lives does something quite interesting, which is unusual in adult services. It brings together those two worlds, the world of a regulated service that CQC comes and inspects, that has all of the infrastructure you'd expect from that, as well as ourselves at Shared Lives Plus as a national membership body doing policies and procedures and learning materials and communities of practice and all of that. But it also allows people enough autonomy to form whatever home and family life happens to feel like to them. So it brings together that professional and personal world in a way that we often struggle to do. We make people choose between getting the support they need or living the life that they want. And as that quote there from Shared Life Carer who kept up her nurse registration when she became a Shared Life Carer said, "I'm still using my nursing skills, but it feels very different in my kitchen to the local hospital ward." So could more of our social care services behave in this way? And what stops approaches like Shared Lives, of which there are a number now in the UK, becoming the core of this system? If we intuitively feel that this is how we might want to live our life, and if not that many of us dream of living in a care home, why are we not building our system in that way? So Shared Lives is a useful example because it has scaled to a point. There are 14,000 people using it. If you live in the UK, you almost certainly have a local Shared Lives scheme. It's now being used as a health service as well as a social care service, and CQC consistently say it's better than everything else in regulated care. It's also lower cost. So it isn't just about evidence. There is something else going on here about scale. It's something we tend to talk about as a culture shift. I'm always suspicious of people, particularly people in positions of power, talking about cultural shifts, because I think we're often describing the kinds of changes we don't really believe are going to happen and that we probably feel aren't entirely our fault if they don't. I think there's something more systemic going on here. It's something about that system that we continue to build and maintain and that I think is all pervasive. So there are lessons to be learned from a model like Shared Lives. Some of them are practical. It takes a lot longer to get the right people involved, months rather than hours or days. Because it gets the right people involved, it has that confidence in them to allow them to form a completely different kind of relationship with the people they support, one in which they involve their family and friends, which feels like family life, as well as having that formal element of a regulated service. And that, I think, is the part of reform that we don't talk about. We're investing so much energy in surviving the system we currently have, and in shoring it up, in reconfiguring it, extending it, merging it, and all of that other stuff that feels very complex and pressing, that we haven't really stopped to think about the support relationship that is at the heart of all of our long-term public services. That what is currently a client professional transaction. And actually, as we all know, the challenge isn't those brief interactions that services have with people when people need fixing or curing. We're actually really good at that. It's the journey that we go alongside people with for decades often, for when people have one or more long-term conditions. And that's not a support challenge, that's a relationship challenge. So what kind of relationship do we want to have? We certainly don't want a succession of different strangers coming in and out of our lives. And that's often thought of as just an inconvenience, and it's not actually. It's damaging to our health. A family carer described more than 100 separate strangers providing intimate care to her husband who has dementia. That's not an inconvenience, that's damaging to his health. So you won't necessarily be able to see this, but I think the slides will be circulated. This is a family of approaches like Shared Lives which take that different approach. They're asset-based. In other words, they look for what people can do, what they can contribute. They recognise that people with support needs want to contribute. They don't just look for what people can't do or what their needs or risks are. So the CARES family, North London CARES, South London CARES, Gig Buddies, Compassionate Neighbours from the hospice movement, Keyring, local area coordination from Australia, Buurtzorg from the Netherlands, and others. They look for what people can do. They organise, they provide a framework for people to have a smaller set of more consistent relationships. And they also try to connect people with each other, not just with the service. Could we build an entire system around these? This model will be on the Think Local Act Personal website quite soon, and it suggests that actually we could, because it looks at a whole range of ways in which services interact with people's lives. We're only going to do that if we reframe not just our bit of the system, the community end or the preventative end, if we reframe the entire system. The Care Act tantalisingly suggested we might do that. It said the purpose of social care is well-being, but it didn't go on to say how we were going to measure, commission, regulate for, demand, pay for well-being. So we have this values gap between these initiatives that we like the sound of, who are doing things very differently. We like them, we don't value them. So we need a system that's based around well-being and resilience, and that requires all of our long-term support system, which is actually a vast part of the health and care system, as well as a number of other areas of public service, to be able to spend more time getting the right people involved, to form deeper relationships, and to connect people, and be mindful of how we're disconnecting people as well. We're terrible at measuring outcomes in social care. We're even worse at measuring the negative outcomes of what we do. We don't look at the impact on somebody's well-being as a whole. We just define success in our own terms. My very reasonably priced book goes into how that could happen in more detail, and is available from almost no good bookshops, but the Policy Press have it. So we can only do that if we think whole system. There are a number of resources there which you can look up, which say, let's think whole area. Some of our work with the NHS, bringing this countercultural model into the NHS, has seen the NHS locally invest in the provision, but then not actually be able to use it because there's a whole lot of system change around the care pathways, the referral agencies, which doesn't happen, and which is needed if you're going to see these initiatives happen. So you need to be doing this on a big scale with lots of different community initiatives, and you need, like Wigan, to be thinking about what we are telling a different story to our population. So, just a couple of words to finish about James and Andy. So, James is somebody who's considered to have complex needs, and his medical needs are quite complex around his epilepsy and his learning disability. He lived for 20 years in an epilepsy centre, which he describes as boring. He didn't have much of a life there. And people, again, scratch their heads about, well, what do we do with this guy who's got such complex needs? But actually, there was nothing complex about his needs. When he drove away from that centre with Andy, who became his shared life carer, to move in with Andy and his family, his needs were really simple. His goals were really simple. He said, I want friends and a job. And Andy and his family, an extended family and friends and neighbours, sat around helping make that happen. James has lots of friends, several jobs, he volunteers, he does karate and gardening, he has a full life. He has his own place now around the corner from Andy, but they are each other's extended family. We need to stop tinkering with the complexity and start offering people simplicity. Thank you.
I guess all linked to this idea of prevention and how do we ensure that more people have a good later life, which is the goal that we have at the Centre for Ageing Better. And I think the first that really came through, both from what I also know in more detail from what Natasha found in Japan, is this idea of community support. And that it's so critical to create circles of support, that informal support in our neighbourhoods and places where we live, to really help us with some of those small everyday things that might just otherwise tip us over into needing more formal care, but also that give us meaning and purpose, bring joy to our lives. And it was great to hear Alex and show that slide with a lot of community-based organisations that we're aware of, some of whom we're trying to help evaluate what they're doing, which are really all about this idea of creating connected communities. Intergenerational relationships. I go and volunteer with North London Cares. It's just fantastic. They don't talk about older people, and we're neighbours, and it's about getting to know each other. And so I think there's a lot of really great innovative things going on out there to really build that strong community and social resilience that we heard about. The second was housing. And just the underlying, really, Alex's point about the need to innovate in how we, in housing. Everything at the moment is very age segregated. This idea that we want to live in a retirement community or that housing needs to be special for older people. I mean, clearly there is a need perhaps for some extra care housing and specialist housing. But for the majority of people, particularly in those years leading up to a point perhaps where health creates a particular need, there are many active years still to be had, but we may experience some limitations with our capacity. And having an accessible home could make a huge difference to our well-being. At the moment, the statistics are that only 7% of the housing stock in this country meets even the most basic accessibility standards, and by that it means it's visitable. So no steps up to the front door, level threshold, loo on the ground floor, a bit of circulation space to sort of move around. So we've got a very, very low base from which we need things to change. So really needing to change the mainstream housing to make every new house accessible from the start, and to do a lot to convert and adapt our current housing. So lots of innovation needed in housing models. If we don't want to end up in this age-segregated institutional sort of care that Alex talked about there. And then the third thing I just wanted to touch on was this point about informal carers, which came through really strongly, that Japan and Germany, I think particularly Germany, thought really hard about valuing informal care. And, you know, the idea that carers allowance, I mean, it is an absolute pittance, and there needs to be a really, really honest discussion about what we should pay for the value of that informal care, because otherwise We are mostly women exiting the labour market to do that caring, and that is leaving them much more likely to spend their own later life in poverty. So those gender inequalities in caring that are there for small children, they carry on with care for older adults, for elderly family members. The other thing is they do lead to an exit out of the labour market at the moment. So we're really pushing hard to see carers who are in work. So we know that it's one of the leading reasons why people fall out of work in their 50s and 60s. Is one of them is health, the second is caring. So things like we've heard there, flexibility, rights to leave, rights to return after a carer's break, are things that are going to make a massive difference to people's ability to remain in work and to combine that with caring responsibilities. So I think recognising that whatever we need to do on funding and all the things that I'm sure we'll all debate, it was really refreshing to sort of hear as well that we have to put this alongside other changes. Otherwise, the pressures on the formal system will just be too great. We won't have the people in terms of the workforce, and we won't have necessarily, let's hope we'll have more money. But so let's also think in the round about prevention, about housing, about community, and about informal carers.
Thank you. Sharon.
Thank you, and thank you both for your presentations. And one of the things that I was really struck by from you, Natasha, was the point you made about the lack of public discontent about the state of social care in this country. And it's something we hear a lot. Sir Andrew Dilnot talked about it this morning. Interestingly, he kept referring to Matt Hancock as the Secretary of State for Health. And there's somebody here from Health Service Journal. I think you call him the Secretary of State for Health, but social care. And the point was that health can go and say, look, we're going to have a real crisis. There's winter pressures coming. We don't want people on trolleys in corridors. And what we say about social care, and MPs continually say that people don't write to them, their postbags are not full of people, their surgeries are not full of people complaining to them about what's going on or what's not going on in social care. And I think there's two reasons for that. I think one, well, there's probably a lot of reasons, but the two I'm going to share. One is just about the touch. So in social care, we're supporting around 1.6 million people a year. And Caroline will talk about the numbers that we're not supporting because they're not able to find the social care they need. But the numbers in health are huge. I think it's something like 500,000 people a week using accident and emergency services, and that's just one small thing. All of us have a connection with the health service. We're born usually in a hospital. We use NHS services, but not that many of us engage with social care. So there just isn't the same level of traction. And then there's something about your reference back to the Poor Law, Alex, about whether we are responsible somehow for needing support. And this was brought home to me very forcibly by one of my former board members, who is someone living with long-term conditions, who employs her own team of personal assistants to support her. And she just asked me, Sharon, why is it okay for me to be ill, but not okay for me to need support? Couldn't answer that one. Still can't answer that one. I don't really understand what the difference is. If we start from a basis of citizens who need support, whether that's about their health needs or about their social care needs, we should be providing that in a clear and coherent way. And just to remind us as well, and Alex again portrayed this through his presentation, that social care is not just about older people. Most of the media focus on older people. Actually, more than half of local authorities spend on adult social care is about people between the ages of 18 and 65, people who need support to live a full life. And that could actually be any one of us, couldn't it? Because things happen, and we need to think about how we can provide care and support in our communities that enables all of our fellow citizens, including those close to us and including possibly ourselves, to achieve just that. And you would expect me to therefore reference the workforce. So we have a very big workforce in adult social care. but as has been said, a massively undervalued workforce. And again, one of the things that I noted from your report, Natasha, was that the flat rate of pay for social care providers has had a real challenging effect on the workforce because it's depressed wages. Well, let me tell you, we cannot afford to do anything that is going to depress wages in social care anymore. I have said numerous times, and I'll carry on saying it, that it is a source of national shame that the social care workforce is talked about as a minimum wage sector. It should not be. They are providing care and support for the most valuable part of our society, our loved ones. Why do we think it's okay to say that they are only entitled to minimum wage? And while I'm on my soapbox, please, please don't ever fall into the trap of describing the sector as low-skilled and low-paid. It is the former, it is not the latter. And if I can make one plea to all of you, it's when you go out of here, if ever you hear anybody saying that, you correct them on that. And thirdly, I think there is actually a huge role in prevention for the social care workforce. So social care workers are working alongside people. They are forming deep, long-lasting relationships with people when we can keep them, and we haven't got the churn that Alex talked about. And so who better to work alongside people to look at things like diet, like nutrition, like exercise, like smoking cessation, like managing drug and alcohol use and many other factors. And yet, are we making that link? I don't think we're making enough of it. So I think there's huge amounts that we can go at. We absolutely need reform. I like elements of the Japanese model. I like elements of the German model. And I'm also interested in looking at what's happening in Australia. And indeed, we can even look closer to home, can't we, about integrated systems in Northern Ireland and Scotland. Is it beyond our collective ability to take the best of all of these different models and create something really positive for our future? Well, I don't think so, and I would be very interested in having that conversation.
Thank you very much, Caroline.
Oh, lucky me, I get to follow all of that. I think this might be one of those panels where we're in danger of all being in violent agreement. So I don't know if I can say anything a bit edgier to sort of gee us all up a bit. I think one of the things I thought, listening to both those two really good presentations, was how different they were. And therefore, I felt a bit sorry for the Green Paper officials trying to write this thing, because what exactly are they there to write about? You know, so is this about funding? Is it about, when you think about who actually receives care in our country, it's an enormously diverse range of people. And although the care may look the same, it means very different things to people depending on their situation. So you might be talking about a learning disabled young man who's got hopefully a long life ahead of him. It's crucial that he is empowered, he's supported, he achieves his potential, he has hopefully a personal budget to help him do that, personal assistance. There's a particular feel to that. Then you have people, I think, in midlife who develop horrible conditions like MS, MND, become very seriously ill, and they need often more personal care. Or you have people with mental health problems that might have gone on for a long time, like the example that Alex gave as well. And then you have older people. And when we're talking about older people, we're in a different ballgame altogether. I do think this is partly why the discussion about social care is so difficult with the public, because most of the public associate social care as the thing you need when you're not coping so much and you're getting towards the end of your life. And if there's one thing we still really, really struggle to talk about in our society, it is, after all, death. And the fact that you're probably going to need, if you're going to need social care, you're most likely to need it in the last couple of years of your life. People aren't stupid, they kind of know that. And I remember very soon after I started at Age UK, an older person said to me, you know, there's only two groups of older people. You're coping or you're not. And I think people are quite conscious of that, and that therefore makes it, for all the very good and powerful and empowering things that social care undoubtedly does, it's fantastic, committed staff, the marvellous work that happens through informal care as well. In the end, you know, people aren't stupid, and that's partly why people don't like thinking about this stuff, particularly when it comes to older people. And also, when you're talking about that, you're usually talking about personal care. So I never like to let Sharon down, not least because she's on my board. And I will talk a little bit about the fact that there are 1.4 million older people in our society who have some unmet need for care. And that's an unmet need for personal care. That's people who are struggling to do something like wash, dress, get out of bed, cook a meal, just organise those very basic day-to-day things. And a lot of the work that we do in Age UK, and really where the system essentially focuses around older people, is about whether they are or not getting those sorts of needs met. And of course, it's that particular group, particularly frail older people, who are really of most interest in lots of ways to the NHS strategically, because, and that's why there's quite a lot in the long-term plan about them, because this is where you see the interface of failing to meet people's care needs at that time in people's lives. You're absolutely setting them up to need a lot of medical intervention, possibly an otherwise avoidable admission to hospital, back into the whole detox debate and all the rest of it. So I think when we talk about social care, we might be talking about something that's quite preventive. We might be talking about supporting people to age well, which is obviously the meat and drink of what Anna and her organisation does. We might be talking about helping a younger person to have a rich and fulfilling life with lots of relationships. It's not to say that older people don't need relationships too. Of course they do. I mean, this is a relationship-based business, but whoever you are, it's all about that. I totally agreed with the comments about robots. You know, can't see robots doing this anytime soon. They might in the end, but they're not going to do it, I don't think, in the near future. But it's also, you know, critically about how do we pay for older people to get the personal care that they need that they're really not getting. Just a little point about carers too. I totally agreed with what was said about carers and how badly they're being let down in this country. And you could compare the more generous systems in both Germany and Japan, whereas we pimp off informal carers here. As Anna said, the amount they get is a pittance. If you give up work altogether, the carers allowance is less than JSA. I mean, can you imagine it? It's even less than you'd get if you were in a system which is acknowledged to be pretty mean to people who are out of work because of the conditionality of wanting to get them back into the labour market, whatever you think of that. So, you know, we've kind of ridden on the back of between 6 and 7 million people in this country for a long, long time. And the pips are beginning to squeak because there are more and more women like us, who are actually having to leave the labour market because we can't actually find good care for our loved ones. And to be honest, no one's ever cared very much about poorer women leaving the labour market, because why wouldn't you like that if you were the Treasury, actually? That's not a bad thing to want, really, because actually that's probably cheaper in Treasury speak and think than it is to actually pay for a decent care workforce. But what we're seeing now is actually all sorts of women, and men too, people like Andrew Dilnot even, you know, people who are highly successful professional figures of both genders, finding there are care deserts where their parents or their loved ones are, and feeling they're facing impossible choices to know whether to provide care themselves or pay, or because they can't find someone else to do it. And the poorer you are, the worse it is. So I think there's lots to learn from Germany and Japan. I think they're the way to go. I very much hope the Green Paper will be brave enough to kind of surface some of that. But that's not to say there isn't a place too for all the sorts of things Alex was talking about as well.
Fabulous. Now, a chance to have a conversation about that very rich input. So Martin, I think, had his hand up first, and then there.
Martin Marshall from UCL and the Royal College of GPs. Thanks very much. Two really brilliant presentations. The idea that we should draw more effectively on the assets that exist within communities and families seems so obviously a good and positive idea. It's remarkable that it's never really quite caught on, despite talking about it for a long time. I wonder whether part of the problem is it's both aligned to a left-wing ideology and a right-wing ideology, and therefore is criticised by everybody. I wonder if the panel has got any solutions as to how we can address that.
Okay, and we'll just take a second question.
Thank you. Jeremy Hughes from the Alzheimer's Society. I just wanted to go back to the Green Paper. I do feel a bit that the Green Paper may be like John Appleby's fax paper, that by the time it comes out, we'll find it's blank, because it's been so long in the waiting. But I think there is a concern that it'll be a sort of like a green herring rather than a green paper. And I'm worried that wrapped up in it will be things that we should just be getting on with anyway, that don't require legislation and don't require consultation. The funding clearly is a big issue, which probably does need some discussion. If we can kickstart that, that would be good. But one of the areas I'm worried about is that, in a sense, the success, or the partial success you might say, but I'd say success of Simon Stevens in securing a financial settlement for the NHS was at the expense of a financial settlement for social care. And the Treasury, and to a degree, 10 Downing Street, seem to reiterate that there is no money for health and social care. I wonder if there's something we should be doing around workforce that starts rebalancing that proportion of money that goes to different areas, picking up on Sharon's point. So if you do take the robotics agenda and look at AI, it's quite clear to my mind that if you look at AI, within 20 years, maybe within 5 years, the bank manager role may well be replaced by a machine, and therefore we should perhaps be paying the care worker, which depends on human skills and engagement, what we're currently paying a bank manager. Now, to be a little bit more controversial, maybe quite a lot of the work of a GP might be replaced by robotics in diagnosis, and maybe more of the money that we currently spend on clinical healthcare workers should go on social care workers.
Right, so beginning with the practical challenges of the asset base that Martin flagged up. I mean, Alex, you've probably been closest to that, but then Anna, you might have some reflection. Well, I'll take others as well.
Yes, so it does make sense, doesn't it? And I think and yet it doesn't happen. And I think the reason for that is that, or one of the reasons for that is we create the most powerful jobs around the biggest budgets, not around the budgets that you're talking about, the assets out there in the community. So it's probably not surprising, therefore, that we have hugely complex and involved debates around those big areas of cost within the system, because it's easy to there is nobody whose job it is to, certainly at a senior level, to think about the assets. And that's also, I think, comes into why we ignore family carers, despite the fact that we know from Carers UK and others that it's 100 plus billion pounds worth of care that's being provided. But again, that isn't anybody's responsibility in the short term. In theory, as we move towards this idea of integrated care systems, if they think about the system, not just in terms of what they're responsible for, but about the whole area and the whole population, then maybe we move away from that narrow focus on just the assets of the state and start thinking about what people can bring themselves. And I think if we did that, we would take a very different approach to family carers, which isn't just about a small amount of money and some breaks. It's recognizing that for a very large number of people, most of their care is provided by the family, with the state in a supportive role. So why aren't we treating those family carers as full partners in care? And that's about access to emergency support and to training and to all of those things that the workforce would expect and needs to care safely. So that comes back to what do we value? And if we only value workforce, kit, and buildings, then we're very unlikely to start acting in the way that you're talking about. But all of us could.
Yeah, I'll come in on that. So I think it's an interesting one about the sort of politics of all of this. And I think there are some difficult politics, particularly when we have a formal care system that is so badly in need of reform and funding, that to talk of, the role of community and the role of family, there's a real risk that it's seen that that is a substitute for a properly funded care system. There has to be choice. There are people who really do want to care for their loved ones and do want to step out of work, but at the moment that is, financially a penalty is paid for that. But what we also see are those who, out of complete necessity, so talking to some of those women who are not economically active in some of our poorer communities, as we did as part of our work around employment support and worklessness, if you're in your options are a very low paid job and you've got some care need at home, you cannot afford but to stop work and to care for someone at home because of the total lack. That is not a choice. So I do think that we need to be careful about this idea of reliance on family. Clearly, the Germans are a little bit more conservative, small c, when it comes to sort of traditional roles of family. They're sort of, I remember living in Germany, they used to sort of say, you know, the 3 Ks for women, which were Kinder, Küche and Kirche, which stand for children, church and kitchen. And that was really the realm that women were to occupy. So in some ways, it's perhaps not surprising that they developed a system that effectively rewarded a sort of quite conservative model of people, you know, caring for their loved ones. We saw the opposite in Japan, wanting to get women into the labour market and economic drive for labour participation. You know, I think in this country we are hopefully further on than Germany in our gender politics, and we have very high labour rates. So I think it would be impossible to go back to a situation of thinking that we can rely on family, but we do need to give those people who actively want to, whether it's as a spouse or for their parent, to be able to care and provide those aspects of care that they want to. And sometimes the very personal aspects, they may actually choose not to for the dignity of the family member. But it's about having, I think, a good balance. And I don't think community can ever substitute for a need, but it's a hugely important part of having strong relationships in a place.
Did anyone else want to come in on the practical thing? Or shall we go on to the workforce issue? Yes.
But if I can just say something about the community element, I think that we need to think about what we actually mean by that, and remember because people are living longer, the complexity of care that they actually need. And for any tweeters in the audience, please stop now, because I never talk about my family publicly, but I will just say that my dad is carer for my mum living with dementia. I was with them last weekend. The man is exhausted, and my mum can still bath herself and dress herself. That's about it. So I think we have to be really realistic what we're talking about and what we're expecting of people. Okay, can tweet again now. So I think, Jeremy, you know that I am absolutely passionate about much greater recognition for the social care workforce. And one of the things I think we need to address urgently is parity between the social care and health workforce. And I'm not just talking about money, but let's talk about money for a minute. So if you are a healthcare assistant working in the NHS, you will probably start earning about £17,500 and you'll have an NHS pension and da-di-da-di-da. If you are a care worker in social care, you will likely earn £15,300 and you will have the minimum pension available to you, and you'll probably have to pay for your own uniform if you wear a uniform and your own learning and development. Now, how can that be right? How can that be any kind of basis to try and bring people together and say, we want you to work with the citizen at the absolute heart of what you're doing, they're your focus, and we want you to work alongside each other, side by side, complementing each other's skills and abilities. We have to address the parity issue. I think there are some amazing opportunities through digital applications and robotics, but I agree with Carolina. I'm very pleased to hear you bust that myth of everybody in Japan being looked after by a robot. You know, I think if I get to that stage, I would prefer one of those toilets that does everything for you rather than a person having to do that for me. But if I need someone to put their arm around me, or someone to go to the pub with me, or whatever else that's social, I would like that to be a human being, and long may that continue.
Cool. John, and then, yep. And then actually should go onto the table as well. Yep.
So I'm going to commit a heresy again, which is, I was really struck by something Natasha said about the alignment between social care and the health system in Japan and Germany. And that was apropos of funding models. But I'm also thinking about structurally. So I've talked to a lot of people in social care about what if social care was part of the NHS. And I then run out of the room before they come. But the reality is that the NHS is a national religion, and local government since 2010 has been a whipping boy for austerity. Sometimes when you're in a really desperate place, and I feel quite uncomfortable about the notion of it, but is it time to have a debate about that?
Okay, well, you've got another person on your table, just there, yeah, and then Tom behind you. I'll take the three.
Thank you. It's Anne Hagel from the Association for Young People's Health, and my question really is about how we involve young people in the discussions about where social care goes. And Anna said something about age segregation and the increasing amount of age segregation. And of course that works both ways. So if older people are segregated, so are also younger people. And other people have talked about the need for cultural change and a lack of public discontent. But young people in many ways are amongst the most socially conscious. They volunteer the most. As a generation, they are amazingly fantastic at all this stuff. And how can we broaden the conversation so that they are part of our discontent about what is happening in social care and can be part of the solution?
Right, and just take Tom behind you because there's a cluster of you there, and then we'll take...
Hi, Tom Downs, geriatrician in Sheffield. Brilliant presentations. I'd like to, Natasha, an observation and a question for you. Observation, I took a day's annual leave last year as a geriatrician and spent a day with a home carer. And it was a day I should have taken much earlier in my career. I remember asking her what she liked and didn't like about her job, and she started talking about the phone she had with the app on it. I thought this was going to be what she didn't like, but it wasn't. It's what she liked. It was a beautiful implementation of technology. And she said, I'm out here on my own in the community. Within 15 minutes, if I'm not where I should be, then somebody's on their way to come and find me. I really like this. And what she said she didn't like was that she didn't feel that district nurses respected her. So when you make the point that it's not just about pay, it's about status, that really echoes with my experience. There's, for an NHS doctor, that was very embarrassing to hear. My question is last month the BBC Mainstream News carried a story about the doubling of the rate of crime in Japanese pensioners, and they described the main drive for that being that it was obviously culturally absolutely contrary to Japanese culture, and yet it was minor crimes to get short prison sentences, and the case they were making was that they couldn't survive on their benefits while they were in prison. Their benefits continued to get paid, so it allowed them to maintain their lifestyle in their non-prison times. That is in the context of the system that you described, which obviously their demographics are way ahead of ours, but so much more organised with a collective insurance model. So my question is around where you talked about the population support lacking in the UK. We're not uncomfortable enough. Where is the discomfort going to come from in the UK? We hear a lot of rational discussion going on in this room, and yet something has got to happen that makes us uncomfortable enough to get this sorted out.
Gosh, so three big questions. Does anyone want to pick up? Shall we take Tom's first, the sort of level of discomfort? What is? I must say, Tom, as I've been listening, that my head was going back to the closure of the long-stay institutions, which is actually where, and our level of discomfort after a number of very public reports was enough. Finally, it felt to me to drive that. We've had some exposure of some of the shame that has been described here collectively, but maybe not enough. But
yeah,
Natasha?
I saw that article about Japan too, and I was quite intrigued by what that was about. I think some of the questions around how do we get to that point of discontent, I think it comes back to the issues that some of the panel reflected on about social care just not having that visibility, the same visibility that health has, and that you don't know what it is until you need it. And I think that's a fundamental problem that we have about how we have this conversation with the public. So somehow we have to raise that awareness about what social care does and what it delivers. And I think the key to that is some political leadership, because I think that's really what's lacking here. And just going back to, I think, Jeremy's point or question, do we need legislation to deliver this? I think we do, because I think it has to have that national visibility and that backing, cross-party backing, to really raise awareness and to make change happen. I don't think we can carry on just doing little bits around the edges. This has to be a fundamental reform that looks across the whole piece.
Natasha, while we've got you, do you also want to pick up on John's point about the structural change?
The alignment, yeah. I feel a bit conflicted about whether health and social care needs to be integrated. I don't think necessarily. I think it works in Germany and Japan as two separate systems. I think we can have greater alignment between the two systems, but it's not just about the structures. And I think there's, learning from wider integration research into that it's not about the structures. It's actually about the working patterns and the working cultures and the communication between different staff groups and organisations. I think we can have some national structures in place that facilitate greater integration, but I wouldn't necessarily call for a structural change there.
Anyone else views on structures, or we'll move on to young people and their engagement? Yeah.
So in terms of alignment, at the moment, if we merged health and social care, we'd merge everything around the local hospital, I think, because I think that's where the power base lies, and that would take us in exactly the opposite direction to the direction we constantly say we want to go towards communities. So I think we should be aligning everything we do around a set of shared well-being goals, but we need to be able to do that rather than just align everything around wherever the biggest public service power base is at the moment. And on status, I think you can't separate the low status of the social care workforce from the low societal status of the people receiving social care. So we have a much deeper issue around how we regard older people and how we regard disabled people. And so there are some really big issues about power there, including having discussions like this and who's in the room for those discussions. But I think that's where some of the approaches around that have given people power, sometimes in the form of money, individual control of money, become a really big part of this, and how we see the status. And just very briefly, if I can, on the young people element, alongside the work we do with Shared Lives, we support something called Home Share, in which an older person with a spare room is brought together with a younger person who needs somewhere to live. So that was sort of thought up largely around loneliness for older people. It's actually equally about loneliness for younger people. And if you talk to the people involved, it's about the relationship. And actually, they do completely change their view of each other. And it makes me feel that actually this idea of kind of intergenerational battles is something we are constructing, not something that's inevitable.
Yeah, I mean, I would agree absolutely that we have to have, relationships with each other across generations in order to break down any suspicions. But I think that they're overblown in public debate. I mean, we see all sorts of things about, older people sitting in mansions, or, we've moved on from bed blockers to, room blockers, in the sense of, this debate about downsizing. It's complete rubbish. You actually, you ask older people and younger people, and they are all as concerned about these big structural challenges that face us, that the housing market is broken. But they don't blame the older generation for the fact that, house prices have gone through the roof and are shutting them out. The fact is, many of us have intergenerational family relationships within our own social circles, where we clearly understand these issues and we understand each other. And yet it seems that, in public debate, we get split off into, we're either baby boomers or millennials. Well, so I think really there is a need to engage everybody in a discussion about what's the future we want for ourselves. If we have, if we were unfortunate enough to have a stroke tomorrow, or, many of these things are things that we can all experience ourselves actually at any age. And I think there is a conversation about what is the care that we think in a wealthy society, as Andrew showed us this morning, what are we choosing to spend our money on? And at the moment, we are failing to choose to spend money on giving people dignity, care and support at a time of need. And I think that that is the shame that we should have all of our political leaders saying, you have to do something about this. And I don't have the answer why not. But, if this room isn't angry and going out there and making noise, well, let's at least start by doing that and see where we get.
Yeah.
And I'd pick up this visibility point too, and pick up Tom's experience of being exposed to the lived reality of some of the lives of some of the people that are then coming into hospital. The number of people that have talked to me about being exposed to the whole of the care pathway of which they form a segmented part, and the sort of revelation that then gives them about what the intervention points might be, how they are just a small bit of a bigger whole, how actually understanding somebody else's role allows you to work with them in a totally different way. So, again, it's this point about the relationships and understanding to help sort of see some of this stuff, I think is really key. So, where's our next cluster of questions, Dan?
The lady there with the microphone.
Lady
Judith
there with
with
microphone.
the
The lady there, Judith.
Nice to be a lady, thank you. Some days. Very often I'm told that. Judith Smith from the University of Birmingham. I'd be just really interested to hear from some or all of the panel. What's the one main thing they took from Natasha's account of Japan and Germany? What's the one lesson we can take for our social care funding and services and approach here in England?
Okay, and we'll take another couple. Yes, here.
Angela Coulter. I'm interested to know what the panel think about direct payments stroke personal budgets. Are they part of the solution for the future, or are they part of the problem? I'm particularly thinking about knock-on effects on the workforce.
Okay, I think we'll just take those two questions because those are directed at the whole panel, so that implies a lot of answers. So, Caroline, do you want to
on direct payments and personal budgets, I've got an email here from a commissioner of my mum's CCG, because I've had to contact her because I'm still waiting for her personal budget to come through. So I'm a little bit conflicted on that one. I think there's no doubt that the reason personal health budgets are quite popular with the government and policymakers is because it feels like a good way to disrupt a system that they think needs disrupting. The problem with it is it's a very slow burn way of doing it. It's a bit of an alibi for not actually taking coherent action from the centre to really drive change. And as you suggest really in your question, there is a problem about whether this then renders impossible more collective or more difficult collective approaches to meeting people's needs, sometimes regarded as somewhat old-fashioned, like day centres and lunch clubs and things like that. Although, frankly, we hear from a lot of people at Age UK who actually really enjoy those things and are absolutely desperate to see them closing all over the place because there's no longer the money to afford them. And I think that's probably the rider that needs to go with anything that we talk about in terms of social care. It's one thing to have a really good idea, but all the time we're trying to introduce really good ideas into a system that's essentially broken and chronically underfunded. And therefore, you not only don't always get the benefits of the good idea, you sometimes actually end up with perverse outcomes as a result, which is one of the difficulties, I think, for politicians in sort of grappling with what to do about all of this. And to answer the other question, what's the one lesson, the most important lesson, I'd say, and I'm quite familiar with both systems as well, I think it's really simple. It's what they've both done is that they've accepted that the state has to be part of the solution, and we have to have a system that pools risk across the whole of our population. And that is really difficult, frankly, for this government to do because it's counterintuitive, that they always want to veer towards some kind of private, individualised solution, so we all have our own little insurance account or whatever. And the problem is, for all the reasons we've just discussed, social care does not have a profile that means that people want to save money into it unless they're made to do so. And so really, that's the big conceptual leap that those countries have made, which I think we need to as well, which is the need for the state to say, I'm really sorry, we're going to have to do this. We're all going to do it. If we all do it, we'll only have to pay a little bit each, and we can all be free of the huge anxiety of what's going to happen to us if we get older and suddenly develop a care need.
Thank you, Sharon.
So I'd love to be able to say, I completely disagree with you, Caroline, but I don't. I completely agree with you in terms of what needs to happen. So the first thing that needs to happen is that we actually need to do something. So that is about political leadership. And I think all of our fears is that the Green Paper, will it ever appear? If it does appear, how green is it going to be? Because it's been talked about a green paper, just to kind of put a few more floaty ideas out there. And actually what needs to happen is to seize the moment. And there have been a number of pieces of research done that show there is public support for some kind of taxation, however that's done. And the point I completely agree on is that this has to be that shared responsibility, a shared endeavour between all of us. You know, I have never had children. I never wanted to have children, but I've always paid part of my taxes towards the education system without any resentment. I want our young people to be educated, and I want disabled people and older people, whether they're part of my family or not, to have a good quality of life, and that has to be paid for. On the question of direct payments and personal health budgets, I think they absolutely are part of the solution, emphasis on the part. There are many things that we have introduced, and we run the risk every time we have a new initiative of saying this is nirvana, this is the panacea, and everything else is rubbish. So they will not work for everybody. I've heard individual employers, people using direct payments, talk about themselves as reluctant employers. They're using it because they just cannot get what they want in any other way. If there was another option, they would take it. It needs to be a more flexible system, so people can kind of flex in and out of it as their needs change, and it needs to be part of the solution. I think your concerns about what that might do to the workforce, there are two sides to that. So on the one hand, actually what we know is that people who use a direct payment or personal health budget or their funds through some other form to employ their own care and support staff usually pay them much more akin to pay levels in the NHS. There are stronger relationships because it's a one-to-one relationship. People are choosing the people that they're going to be supported by, usually from networks of people that they know. On the other hand, it can be fragmented, it can be lonely, and of course, if there is an issue of discord between the individual employer and the personal assistant, that is incredibly difficult for everybody. And we must recognise personal assistants as part of the workforce and think about them when changes are coming in, like pension auto-enrolment. Nobody thought about that when levels were being kind of considered about direct payments, and we have to think about people using direct payments and personal health budgets are employers. They have responsibilities as well, and they need to be enabled to fulfil those responsibilities.
So I agree, obviously, on the point that we need to make social care another pillar of our welfare state. If we want to go back to this morning's discussion, it has to be collective. And we do need to pool. And for whatever, for historical reasons, social care has never been seen in the same way as healthcare. It's always been more individualised, means tested, and so on. So I think we do have to elevate it and put it alongside the NHS in that sense. I think the other bit I took from the presentation was about the sort of consistency, and that's in two ways: the national assessment and clarity on the benefit. So we focus a lot on the funding and not very much on entitlement. And that's partly because we are very vague about our NHS entitlements too, unlike many of the social health insurance systems that are much more explicit about what you are entitled to. And I think we have to move to much greater national consistency in what is the entitlement and assessment process. That doesn't necessarily mean sort of going the whole hog and merging it with the NHS, as one of the previous people was, I think John was sort of asking. But I think it takes us quite a long way there to sort of start and say, how do we make greater consistency between the NHS and social care? I mean, at the moment, we've got this ridiculous sticking plaster in the middle called NHS continuing care. For most people, it's a mess, and that bill is going up and up and up unsurprisingly, it's very contested because obviously if you're on the side get on the wrong side of a decision, it can make a very, very big difference to you and your family in terms of finances. So I wouldn't go as far, and especially not if people are tweeting, to say that it should pull social care into the NHS, but I do think that what I took from those presentations was a much greater degree of national consistency and consistency between the NHS and social care in terms of entitlement.
Yes, I completely agree with Sharon's points on personal budgets, direct payments. Tens of thousands of people have been able to take control, not just of their services, but of their lives. And we should never contemplate taking that right. That is a human rights issue. It's not about whether it's more efficient or whether it's better for the market. If those people were in this room, and they're probably, if this is going on Twitter, I know that people have often come in when personal budgets have been attacked and said, keep your hands out of your politics out of my life. Because people before were forced to accept substandard services sometimes, and actually being able to take control of that, and again changing the status has been really helpful for people. And actually, as Sharon said, when that works well and it needs support put around it, it shouldn't be a free-for-all. It can be create incredibly fulfilling roles for people within social care as well. I think there's a false dichotomy between either we take a very individualistic kind of market-driven idea of what personal budgets are all about, or we take a collectivist, let's just organise it really well at the state level. There are flaws in both of those models, and we don't actually have to choose between the two. They're both based on a rather gloomy view of human nature, a kind of a right-wing view that says people are selfish, but it's okay, the market will provide, and a left-wing view that says we don't really trust people. If you give them individual power, they'll act selfishly, they won't act collectively. And actually, I think what's happened when people have had the individual control but also support to connect with each other is people have started to do really interesting things. But they've done that at the scale of the household and the community and the small group. So we've seen things like micro-enterprises in areas springing up where hundreds of very small groups of people have got together and have started collectively to produce really quite large amounts of care support, enterprise, innovation. So I think we need to trust people to have individual control, but recognise that we need to connect people with each other, help them to use that in different ways and to think about that in different ways. And there's also a really important equalities issue there as well. If there's no advocacy and no support to make choice, then that becomes a competition between those people who have that budget. If we want that to be something that's accessible to all groups of people, we have to invest in advocacy, we have to invest in brokerage and in ways in which people from all communities can start to make different kinds of choices.
Yeah, just to add to that, I completely agree with all those points. In the Japanese system, there's one detail I didn't manage to get in, is that when you're given your virtual budget, you're also assigned a care manager who sits with you and helps you create a care package to help you decide how you're going to allocate your virtual budget between providers. So I think direct payment, whether it's real or virtual, is a problem or solution. I think it very much depends how it's set up, how it's administered, and how people are supported to use it. And on Judith's question, the one thing that we take away, I think it has to come down to the risk pool. It's not all about funding, but I think it starts from there. And that sets the scene, it sets a clear value, and everything flows from there. Now, the two countries I presented use a social insurance system. That might not be the right mechanism for us. They have a precedent of that in their countries, we don't. But the concept of the risk pool is, I think, where we need to start.
Yeah. And that's where we will end. Thank you very much.
Good note.